I would like to invite the next speaker. Dr. Madhu KP. She is my dear friend, my junior at MMC. She is currently Assistant Professor at Department of Anesthesiology, Bangalore Medical College and Research Institute, Bangalore. Her special interests are in the fields of pediatric and obstetric anesthesia, physiology, endocrines, anesthesia machines. She has more than 10 publications in national and international journals and has chaired a pediatric anesthesia session during SZISACON2023 Agra. She has delivered lecture on anesthesia for fiber optic bronchoscopy, South Zone Pulmonology Conference in 2018. Also delivered a lecture on physiological changes in pregnancy, SZISACON2020. Lecture on airway foreign body in 4-year-old rapidly desaturating, SZISACON21. Master trainer in simulation center at BMCRI. Trainee of trainee in BLS anesthesia for fiber optic. 11 years plus PG teaching experience and has been recognized as postgraduate teacher since 2018. She has done her MBBS from BMCRI and MD from MMC Mysore. Hearty welcome. Over to you.
Good morning one and all. I am Dr. Madhu. Warm greetings from Bangalore Medical College. I will be talking on anesthesia for electroconvulsive therapy for another 12 minutes. We will be briefing you about definition, indications, contraindications, physiological changes due to ECT, anesthetic management. It was introduced in 1937 by Serliti and Binney for severe major depressive disorders, and it is defined as a clinical procedure where a small dose of electrical current is passed through the brain for a brief period of time to induce seizures for therapeutic purposes in psychiatric disorders. In 400 BC itself, Hippocrates said that extreme treatment is the cure for extreme diseases. That is how ETC looked like before introduction of anesthesia to ECT. Now we follow modified ECT where we give general anesthesia and muscle relaxation. This is the picture showing the electrode placement where we can give either bilateral or unilateral. A and C are the one for bilateral ECT where we put the electrodes in the bitemporal or bifrontal positions, and B is temporoparietal position. Bilateral one is the preferred one where clinical recovery takes the priority. Unilateral one is done for non-dominant hemisphere where there is less adverse effects and optimum seizure duration is unclear. Less than 10 or more than 120 seconds may reduce the clinical efficacy. Typically performed twice weekly until there is no further improvement. These are the common indications. A few to quote are major depressive disorder, mania, schizophrenia and related disorders, catatonia, autism with severe repetitive self-injurious behavior, dementia, OCD, Parkinson's disease, epilepsy, neural malignant syndrome. Contraindications are raised ICP with space-occupying lesions, unstable cerebral aneurysms, pheochromocytoma, recent history of stroke, recent MI, poor cardiac output, unstable dysrhythmias, third-degree burns, raised intraocular pressure, retinal detachment, fractures and dislocations, and spinal injuries. For an anesthetist, it is the physiological responses to ECT plays a major role, and major brunt is on the CVS and the CNS. It is due to activation of autonomic nervous system. Initially, there is parasympathetic discharge lasting for 10 to 15 seconds, resulting in bradycardia, hypotension, and even asystole, followed by a sympathetic response where there is increase in heart rate more than 20%, 30 to 40% increase in the systolic blood pressure, which peaks in 3 to 5 minutes and lasts up to 10 minutes, where all these increases the myocardial oxygen demand. Cerebral effects are increase in cerebral oxygen consumption, blood flow and intracranial pressure. It can lead to transient ischemic attacks, intracranial hemorrhage, even cortical blindness have been reported. And it can lead to prolonged seizures and even status epilepticus. Most common side effects are adverse cognitive ones where there is disorientation, impaired attention, even short-term memory loss or permanent memory loss is also a possibility. It causes retrograde and anterograde amnesia, but intelligence and judgment are unaffected. ECT also increases intraocular pressure, intragastric pressure, but they are clinically not significant. Physical effects are dental damage, oral cavity laceration, or there can be increased salivation. When coming to the mortality, it is a low risk procedure and it is similar to any other anesthesia for minor surgical procedures. Most common causes of death are due to cardiovascular and pulmonary complications. According to Mental Healthcare Act from 2017, ECT without anesthesia and muscle relaxation is prohibited. And the presence of an experienced anesthesiologist is highly desirable, and goals of our anesthesia are rapid onset and offset of both unconsciousness and muscle relaxation for the duration of electrical stimulus and subsequent seizure. And important one is to minimize the aforementioned physiological and physical effects. So proper history taking, which is not so easy in this set of patients, is very, very important, and history of all comorbidities. And direct questions can be asked on the esophageal reflux, last meal, denture, hearing aids and lenses to be asked, and recent history of MI or CVA within 3 months, and other contraindications as I mentioned before to be ruled out. And invariably these patients will be on many psychotropic drugs, and their side effects and its interaction with anesthetic drugs to be kept in mind. Most common drugs used are antidepressants, antipsychotics, antiepileptics, and mood stabilizers and benzodiazepines. And all the drugs to be continued except mood stabilizers and benzodiazepines in the peri-procedure period. Most important side effects to quote are SSRIs and TCS can precipitate serotonin syndrome in certain drugs, and the TCS can potentiate the vasopressor effects of catecholamines and indirect sympathetic agents. Also, they can prolong the QTC, widen QRS and conduction delays. Then lithium can cause prolongation of the action of muscle relaxants, and anticonvulsants can impact the seizure induction and duration of ECT. To continue with the physical examination, we also should seek for the evidence of cardiac failure, severe valvular disease, dysrhythmias, uncontrolled hypertension, poor dentition, dehydration requiring fluid therapy. And after clinical examination and history, the investigations are based on the patient clinical condition and the hospital protocol, and the time taken to optimize these problems should be weighed against the urgency of the ECT. So where to do the ECT? It all depends on the institutional setup. We can do in post-anesthesia care unit, pre-op area, or there can be a dedicated suite for ECT. But presence of a psychiatrist, anesthesia provider, ECT nurse and a recovery nurse are recommended. So like being an anesthetist, it is the most of the time we spend inside the OT only, so thorough checking of the anesthesia machine, and to keep all the drugs to give general anesthesia, including emergency drugs, defibrillator and monitoring to be placed and thoroughly checked. So consent to be checked and fasting guidelines to be followed according to the ASA standard guidelines, and regular medications which are to be continued, and equipments for monitoring. Especially then other equipments are tourniquet, soft bite block, suction apparatus and airway management gadgets to be kept ready. Intravenous catheter is placed before induction of anesthesia, and pre-oxygenation done with 100% oxygen, and patient's vitals to be monitored throughout the procedure, but we avoid sedative premedications because they interfere with the induction of the seizure and the duration. So IV anesthetic agent of choice is administered, followed by a bag mask ventilation. Tourniquet is placed to the lower limb ideally to monitor the motor portion of the seizure. Then we give succinylcholine, most commonly used muscle relaxant, at the dose of 0.5 to 1.5 mg per kg to prevent myalgia and musculoskeletal injuries that can occur during the seizure. If succinylcholine is contraindicated, we can use NDMRs. So intubation is not commonly done unless there is a specific risk factors. Once induction is done, patient is ventilated with bag mask. Hyperventilation is induced if required, and a soft bite block is placed to prevent the oral injuries. Then the electrical stimulus is administered to induce the seizure and is monitored. Ideally, we should have a seizure of 25 to 75 seconds. Once the electrical stimulus and seizure stops, then the patient is hand ventilated till the breathing resumes. Once he is fit with the spontaneous recovery of ventilation and hemodynamics are stable, he needs to be shifted out for further monitoring to the ward or the PACU. This is the chart showing the different induction agents used and their quality and their effect on the seizure quality, advantages and disadvantages. Gold standard is methotrexate. Because of the non-availability, we can go ahead with thiopentol or propofol, other drugs based on the patient's clinical condition. These are the critical properties of anesthetic agents in terms of their effect on seizure threshold, propensity to increase heart rate, mean arterial pressure and the emergence time. Based on each patient condition, we have to choose the induction agent of choice. To brief the steps of ECT, administration of induction agent, then limb isolation by Hamilton's cuff method, administration of muscle relaxant, and insertion of the soft bite block and deliver the current and observe for the motor seizures. Some of the adjuvants what we can use during the ECT are anti-Silabag, most common preferred one is glycopyrrolate, beta blockers like esmolol, calcium channel blockers like nifedipine, nicardipine, and alpha-2 agonists like dexmedetomidine have been used to prevent the sympathetic effects that occur during the convulsions, especially in high-risk patients who are prone for MI. Most common side effects of ECT are headache, nausea, vomiting, agitation, violent behavior, confusion, amnesia, myalgia. Most common one is headache, where incidence is very high, as high as 85%, needs to be treated with NSAIDs or triptans. Cardiovascular system side effects are acute heart failure, dysrhythmias, even death can occur. This is the data taken from a meta-analysis done over 82 studies. And there is something called as, even while preparing, I came to know that Takotsubo cardiomyopathy, where there is transient reversible stress-induced cardiomyopathy can occur following ECT. Beta blockers have been used to prevent the recurrence of the same during the subsequent ECT procedures. Neurological complications are tardive seizures, which is a fatal complication once the seizure terminates following the ECT, can lead to status epilepticus, need to be treated with anti-epileptic drugs. The TOD phenomenon is a post-ictal focal neurological deficits with spontaneous complete recovery. Now coming to the special patient population, where if ECT is absolutely required in these set of patients, cerebral aneurysm is one, where there is risk of enlargement or rupture during the seizure. We can use sodium nitroprusside or beta blockers to increase this inhibit this increase. Intracranial pressure, raised intracranial pressure due to mass lesions have to be pre-treated with steroids, diuretics and hyperventilation before giving the electrical stimulus. Patients which are prone for neural malignant syndrome or malignant hyperthermia, we should avoid succinylcholine. ECT is safe in pregnancy, but it can lead to potential complications to the mother and the fetus. Patients with pacemaker need special attention. If they are not pacing dependent, we have to keep the pacemaker in the asynchronous mode by placing a magnet on the generator. But if they are pacing dependent, then cardiology team needs to be consulted for reprogramming. Mental Health Act says if the patient is able to understand, we need to take the consent from the patient himself, but involvement of a patient's caregiver or independent person like an advocate is preferred. There is something called as novel seizure therapies like ILAST and magnetic seizure therapy, where to avoid damage to the deep structures like memory retention. To summarize, anesthesia plays a vital role in ensuring patient safety and comfort during the ECT, and many will be on psychotropic drugs, their interaction to be kept in mind, and individualize the anesthesia plans based on the medical history and condition of the patient. And anesthesiologist must not be aware of only the physiological responses and how to modify them, but also understand the anesthetic factors that may influence the efficacy of ECT. So a team work with collaboration between the anesthesiologist, psychiatrist and the nursing staff is crucial for the successful ECT outcomes. These are my references. Thank you. To course